Good afternoon, everyone. I have two messages here, two announcements. One for our virtual guests. Please make sure that you are on mute and camera off. Use the chat. This meeting is being recorded, so you'll have a chance to see it later. But please have the cameras off and the microphones off. Thank you. My second message here is to welcome everyone, present attendees and virtual ones, and our distinguished panel from HRQ, CDC, CMS, OIG, and the VA. Welcome, everyone. Thank you. We'd like to take a brief 3 minutes to ask you for special attention to the following video. Thank you. You know, I live with two words, if only.
My son, Stephen Coffey II, experienced a diagnostic error.
I experienced a diagnostic error.
I experienced a diagnostic error.
I experienced a delay in diagnosis of a serious, life-threatening sepsis.
My 11-year-old daughter, Deonce, who is medically complex, experienced a diagnosis error.
My son, Chad, experienced a diagnostic error.
No one goes to the hospital expecting a medical mistake. No doctor, nurse, or medical staff starts their day to harm a patient. Yet, preventable medical errors are the third leading cause of death in the U.S., right after heart disease and cancer. These errors lead to countless injuries, prolonged hospital stays, and mounting medical bills. Consider the family whose child is born with brain damage due to a preventable error, facing a lifetime of financial and emotional strain. Or the family mourning a father who never made it out of surgery because of a medication error. These are not just statistics. They are real people whose lives are shattered by these mistakes. Unfortunately, most of this harm is never reported, hidden from patients and oversight bodies. This lack of transparency costs taxpayers billions when Medicare and Medicaid cover the additional care required.
What of the doctors who had told me on the phone my son had galactosemia, clearly articulated the severity of his condition, confirmed my understanding, and the medical providers had not deviated from the standard of care?
At the age of 37, Chad died after 16 months of treatment and painful side effects. What if the proper tests were done initially for an accurate diagnosis and treatment initiated earlier? Then maybe he would have survived.
But there is hope. Congress has the power to make our healthcare system safer by establishing nationwide standards for reporting harm, allowing patients to report directly, stopping payments for hidden harm, and closing loopholes that prevent safety improvements. Investing in patient safety is a bipartisan, moral, and economic necessity. We must ensure that every American receives the safe, reliable care they deserve. Let's make healthcare safety a national priority, not a national tragedy. Join us in protecting the lives of all Americans.
I'd like to introduce you now to my colleague, Marty Hartling.
No, I need this, Armando. I need this to introduce our panelists.
You don't have it there?
Nope. Okay, good afternoon, everybody. It's wonderful to see you today. Welcome to our last event of our World Patient Safety Day activities. It's all been a little bit on the fly, so we're really happy that you're here. We've got a number of people online too, over 100. So thanks to all who helped promote this, and thanks to our wonderful panelists for being here. So I have to learn how to use a, okay. So our learning objectives today are really to describe what's being done to implement the National Action Alliance for Patient Safety and Workforce Safety. This is something that Dr. Valdez and Michelle and many other people on this stage are all contributing to. There was a White House ceremony today that we may hear a little bit about, as well as the recommendations of the President's Council of Advisors on Science and Technology. We're also going to shine a light on diagnostic safety. I don't know really who's going to speak on this besides Preeta. I know you're going to talk about it today, but this is the theme of World Patient Safety Day this year, is diagnostic safety, an emerging area of great concern in the patient safety community because missed delayed diagnoses are a problem that we haven't measured well yet, but we know it's really, really significant. We're also at a 25-year point anniversary really from a call to action to make patient safety a national priority, to think of it as a public health crisis in this country. That was in Rose Garden ceremony in 1999, so we are 25 years from that beginning of that work. We're going to look back a little bit at what we've learned over that 25 years, but also look forward to where we're going next, and I know several of our speakers are going to have very thoughtful comments about that. And then, of course, we live in a world where AI is just, in every newscast we see, it's a big factor in healthcare. So we've invited our speakers to share their thoughts about how AI is going to shape the future going forward. So we're very excited to have this group of people here. For those of you who are certified as a patient safety professional, a patient experience professional, or a professional in healthcare quality, you can claim continuing education credits for this. The onus is on you to claim that, but you can contact us later if you've got any questions about it. We are very grateful to these organizations for contributing their continuing education maintenance credits. These are my two colleagues and wonderful friends, co-moderators today, Beth Daly-Ullum. I could say a lot about Beth. She came to us because of an error in her family that had a huge impact. I'll let Beth tell you a little bit about that, but it involved a death. That's what brought Beth to our family. And she's a co-founder of Patients for Patient Safety and a phenomenal leader who spent most of yesterday on the Hill talking to our elected leaders about the importance of this work. And then Michael Millinson is a very old friend. He wrote one of the seminal texts on patient safety and quality in healthcare over 25 years ago, right, Michael? That's when I met you. So a journalist background, now a researcher and an activist, and he is a Patients for Patient Safety champion. By the way, anybody in this room can join us as an individual Patients for Patient Safety champion. You can check out how to join us at our website. It's a 1-hour orientation. You have to be passionate about patient safety. You have to be passionate about working with patients and families to make solutions happen, and those are our criteria to be part of our family. These are our terrific speakers today. I could write pages about each one of them, but I think in the interest of time, I'm going to just introduce them by their title. Bob Valdez is at the far end of our seating arrangement. He is the current the current administrator, director of the Agency for Healthcare Research and Quality. He's got a long background and a global background in quality and safety. Many, many accomplishments, Bob, that I'm not going to take time to mention, but you're a star, and we're very welcome that you're here. You've been at HRQ, I think, since 2022, with a long history going back to the Clinton administration and before that in various sectors, so welcome. And Bob was at the White House today, so maybe he'll have some thoughts to share about what happened at that ceremony. I'm going to go in order of our seating here. Preeta Kudi is from CDC. Preeta is the Deputy Associate Director for Science in the Division of Health Quality Promotion. And Preeta, you, I think, had a personal experience in your family, too, that brings you to this family as well. So welcome, and I had the good pleasure to work with you yesterday and meet you and work with you yesterday. Michelle Schreiber is the Deputy Director of the Center for Standards and Quality at CMS. She's also the Director of the Quality Measurement and Value-Based Incentives Group. She is a physician. She was the Chief Medical Officer, Chief Patient Safety Officer at Henry Ford before she came to the federal government. One of the real strategists at CMS about how we measure safety and quality, and a real leader in developing new ways to measure, including using the various levers that CMS has to really understand how much safety issues we have so that we can actually track our progress. Ed Yackel is the Executive Director of the Veterans Health Administration National Patient Safety Program, which also launched, Ed, if I remember right, 25 years ago. So you're going to talk a little bit about your accomplishments over the course of history, and I look forward a bit. And then Ruth Ann Doral is with the OIG. She's the Assistant Inspector General. Ruth Ann has been there for quite a while. I think, if I remember right, more than 20 years from your bio. And over the course of that time has got probably the best measurement out there about the percentage of harm. And I say that because you don't just look at hospitals, you look across virtually every healthcare setting. I think you've put out 18 reports in the last few years. Not the last few years, but since 2011, and it's just tireless work and a huge service to those of us that are trying to wrap our head around how much harm actually happens in this country. So, a stellar panel. Please join me in welcoming them with a little bit of applause. I do. Okay, I'll mute my laptop. I'm not quite done yet, though. Should I mute it before?
I was going to stand up and do it.
Okay, mute my laptop. It was muted. My laptop was muted.
I'll launch the next one.
Okay, so
You can do that for me.
this is a formulation that we've been using to guide our work and our advocacy and our educational work. We can't fix the harm if we can't see the harm. Patients and families need to be included because we are the only ones who actually see the entire journey that patients and families are on. We can report, we can create urgencies.
Marty, it's the VA slides you're on.
Okay. I want this slide, but we don't need it. I'm going to just speak without slides.
Who do you want next?
Next is going to be Michael or Beth.
Okay, I can just do it for you.
Okay. Mike.
Michael, let me finish and then I'll pass.
Finish, then just pass.
Okay. So the mantra that we have in the work that guides all of our activity here around World Patient Safety Day is let's see the harm. Let's measure it as best we can. Let's discover it so that we can actually track our progress in moving forward. We want you to include patients and families in this work, this very important work, because we're very motivated to help. We might be a pushy partner sometimes, but we're a partner. We can report harm. We can actually help develop solutions. We really want to work with you to try to figure out how we can best use payment to reinforce patient safety. We know there's opportunities there going forward, and we really want to see payment used effectively to reward safety and hold accountable, frankly, organizations that are not as safe as they could be. And frankly, we want to look at kind of the loopholes that we can fix to try to, again, achieve our other goals, which is seeing the harm and including patients and families and really getting the best picture of the amount of harm we have so, again, we can track progress. That formulation really belongs to Beth Daly-Ellen, one of your moderators today. I just kind of stole it from her, but it's what we've been saying as we've developed all of this program. And without further ado, I'm going to turn this over to our moderators, starting with Michael Millinson. Welcome, everybody. Right there, Michael.
Thank you, Marty. So I'm going to do something I wouldn't ordinarily do, which is I'm going to turn my back to the audience, but you'll see why. This is my jacket that we talked about one life being shattered, and a young woman named Regina Holliday, whose husband was killed because of basically some diagnostic error when she was in her 20s. They're both in their 20s here in the DC area, young artists, and she said she was going to paint about patient safety, and they told her no one would ever put those kinds of paintings in a gallery. And so she said, I'm going to have a walking gallery. And she has painted more than 300 jackets with no charge, and they're up to about 500 jackets. Everybody has a personalized message. This is Regina showing me on something to do with my book that I had to have her explain to me because I wasn't quite sure what it was, but that's what it's supposed to be. And I asked Regina why, if my book came out so many years ago, do I have so much gray hair? And she said I was being prophetic. You're also going to, I promise, have a demonstration of AI today that ChatGPT cannot equal. You're going to have actual intelligence. And we have some wonderful speakers. So I wanted to start with a little bit of American history, since we're here in DC, that you did not get in American history class, which is that a medical error killed George Washington, and a medical error killed another sitting president while he was still in office. George Washington was killed by his doctors after he left office when he got a throat infection, and they bled 40% of his blood to try to cure him, and he died in agony. The 20th President of the United States, almost 100 years later, James Garfield, was killed by his doctor, whose name was D. Willard Bliss, with his first name, D, actually stood for doctor. He repeatedly probed a treatable bullet wound with his bare finger, ignoring the advice of other physicians and causing a severe infection. And again, Garfield died in extreme pain. And I mention this history because, unfortunately and shockingly, it's still relevant. Though the type of diagnosis or treatment may be different, the kind of error, no bloodletting, though still plenty of infections, the key point remains that none of us is immune to harm from the medical care system. And those of you who were here the other night when we had our opening dinner heard some incredible stories, as you will hear today. Not presidents or professors, not celebrities or journalists, not the well-educated, even if you're a physician, or the uneducated. From infants to the elderly and anywhere in between, all of us are vulnerable, all of us. And my brother had a diagnostic error a couple of years ago here in the DC area, top 100 physician in cancer that could have killed him. Now, I first realized this awful truth and how disturbingly little was being done about it some 30 years ago when I began researching, writing, and speaking out about patient safety. And as we bring this day to a close, I want to say that I am cautiously optimistic. It's been really an extraordinary time, because there has never been a day like this led by patient activists, including all the different stakeholders. It is truly unique and truly extraordinarily. And I think with the people for patient safety, the co-founders, including my co-moderator, Beth Daly-Ullum, are amazing individuals that really should give all of us really a feeling of optimism about going forward. Now, finally, some might look at this panel and see, a collection of government employees. Others who know a little bit more might see federal health officials. But when you hear what they have to say and consider, their passion for what they're doing, I hope you'll agree with me that what you're really seeing here is 5 individuals who exemplify what it means to be a public servant. So I want to thank them all for coming and everything you do, and pass the microphone over to Beth.
Thank you. I think we'll just get started with the presentations and discussion, because I don't know about you, but I really want to hear from them, because they're in the seats of influence and decision-making that are going to change the face of safety. So I'm not sure who's going first. Bob goes first. All right, Bob Valdez is up.
Good afternoon, and oops, sorry about that. No, turn up this stays like this. We need to move the mic.
Yeah, the mic is
But the mic is reverberating.
Yes,
yeah.
it's supposed to.
Okay. Sorry about that. I'm delighted to join you today to recognize World Patient Safety Day 2024. And thank you to Patients for Patient Safety for organizing this afternoon's event. As many of you know, for me, dealing with the deficiencies in the healthcare system really have to start by listening to our customers. In the United States, healthcare is an industry, let's face it. And we really need to understand how to listen to our customers, what their needs are, and to improve the customer experience. And part of improving that customer experience is improving the quality of care that people receive from our healthcare institutions and providers and clinicians. This morning, I was proud to join the healthcare and patient safety leaders at the White House to commemorate the observance of World Patient Safety Day, and to reaffirm our federal commitment to safe care everywhere and zero preventable harm for all. We've been working hard nationwide to advance patient and healthcare workforce safety, and much has happened since we last came together 2 years ago to take action to review the ground that we had lost in patient safety during the course of the pandemic. In 2022, Secretary Becerra charged the department with creating an initiative which has taken on the name the National Action Alliance for Patient and Workforce Safety, in response to discussions he had with patient safety advocates, some of whom are here in the room with us, and some who are obviously online, with healthcare systems executives who recognized that their systems, in fact, were failing their communities. He tasked ARC to coordinate this departmental initiative to protect patients and healthcare workers from avoidable harm. The Alliance is a collective effort of patient safety advocates, healthcare executives, clinicians, and researchers, as well as federal agencies and federal departments who are driving improvement in the safety of patients and also the safety of the workforce by implementing the National Action Plan, which drives evidence-based strategies for patient safety and workforce safety. This catalyst of change is really trying to make sure that we can implement really harm reduction strategies and share best practices among healthcare systems and among clinicians so that lessons learned will remain learned and not just learned at the moment. The Alliance aims to pursue a total systems approach to improving safety that aligns with the National Action Plan to advance patient safety. And buoyed by the President's Council of Advisors on Science and Technology 2023 report on transforming patient safety, the Alliance has created a momentum in improving patient care quality and safe care environments that we can celebrate today, largely as a result of work that you're doing and the voice that you bring to the agenda. We want to address harm across all populations and across all settings to meet the wide-ranging needs of patients and caregivers and the healthcare workforce, because, as all of you know, we have no national healthcare system in the United States. We have many healthcare systems. All healthcare is local and largely regulated by the states. But what we can do is work together to return levels of patient harm not only to pre-COVID levels, but even better than pre-COVID levels, because pre-COVID levels meant we still had at least 1 in 4 patients who walked into a hospital experience some kind of harm. And that's just not an acceptable situation. On a number of counts, we're seeing a return to pre-COVID levels in healthcare-associated infections and some gains beyond. A new report from the National Alliance partner, the American Hospital Association, found rates of central line-associated bloodstream infections and catheter-associated urinary tract infections in the first quarter of 24 were lower than those recorded in the fourth quarter of 2019. In addition, since the launch of the Alliance, 85% of hospitals have made some progress on the quality of care as tracked by the Leapfrog Group, another Alliance partner. We continue working with our partners in and outside of government to continue this momentum. A newly released report by the New England Journal of Medicine Catalyst, which surveyed healthcare professionals around the country, also found that 75% of clinical leaders were finding that we were making progress in their institutions and also recognized the need to continue this momentum, required us to listen to our patients more closely and to empower more of the workforce so that everyone is part of the team to improve patient safety and workforce safety. Healthcare executives that I speak to around the country have been telling me, geez, if we actually adopt a safe environment and a culture, it actually makes my recruitment of nurses, clinicians, and others easier in a time in which there's a great shortage. Because when you talk to folks, what are the big issues in healthcare? It's workforce shortage, workforce shortage, workforce shortage. But if you adopt and do the right thing, that shortage actually becomes easier to resolve. And for, as I said before, healthcare is an industry, it also adds to the bottom line and produces better outcomes. Now, we must do more to ensure that the patients are not harmed when they turn to healthcare systems for help. As we've learned in the past 25 years of the patient safety movement, focused attention on an issue that must be addressed to increase, this is an issue that must be addressed to increase the trust of healthcare systems that have been lost in communities across the country. At no other time has the trust in our healthcare system been lower than today. And so it's incumbent upon healthcare system leaders, the federal government, and others to regain that trust, to win your trust back by doing what's most important to create a safe environment with effective care. And to that end, AHRQ has been fortunate to have dedicated funds to focus on diagnostic safety, the theme of this year's World Patient Safety Day. The pandemic made visible the weaknesses of our healthcare delivery systems nationwide. We are amid, unfortunately, a healthcare crisis that must be addressed, particularly in our society, and in a society that's aging and where hospitalized cases are becoming much more complex. This is an urgency to reduce diagnostic errors, the delay in diagnosis or misdiagnosis. Best estimates are that about 795,000 people die annually or are permanently disabled each year due to misdiagnoses. Tragically, the patients often misdiagnosed are those with cancer and other life-threatening illnesses for whom delayed or missed diagnosis can worsen prognosis and decrease the odds of survival. On World Patient Day and every day, AHRQ is working to advance patient and healthcare workforce safety through research, developing tools and other resources to help healthcare systems and clinicians deliver the highest and safest quality care, and also to do this in a timely fashion. You can find information about the National Action Alliance and AHRQ toolkits and the other toolkits that are being compiled through the National Action Alliance on the AHRQ website. Through research investments and collaboration with our public and our private partners, we'll continue to focus on patient and healthcare workforce safety for the years to come. This has been a touchstone for AHRQ's 35 years as an independent science agency within the U.S. Department of Health and Human Services. And we are happy to celebrate our 35th anniversary with you as we make progress to patient and workforce safety through the National Action Alliance and the works of all of our partners, and in particular, our partnership with patients and their caregivers. Thank you.
So before we go to the next speaker, we wanted to have a couple of questions. So, Bob, I remember when first I need to disclose that I'm on the National Advisory Council of AHRQ and get paid hundreds of dollars a year. I think it might amount to that much for our three meetings, which take place at glamorous places that I can't tell you too much about, like Rockville. I recall that when the IOM report came out, Congress established a safety center at AHRQ, and it was funded for $50 million. And when I looked at your budget today, 25 years later, it has not kept up with inflation. And so what I'm wondering is, given the fact that, as you said, the private sector is far more aware of patient safety than it was 25 years ago, is there anything that that ARC can do as a federal agency, perhaps the National Action Alliance or something else, to partner with the private sector, with researchers, to sort of stretch your patient safety budget more? Is there some ways that you can sort of get more bang for the buck on patient safety?
Oh, thanks, Michael, for asking the question. I think the National Action Alliance is actually doing what our charter is, which is not only to produce the evidence, to synthesize evidence into actionable knowledge and tools and guidance for the healthcare sector, but to disseminate it and to help healthcare systems and clinicians actually implement it. And we can't implement it. We've got to implement it because we're not a regulatory agency and we don't have the money to pay people to do the right thing. So we've got to actually bring people along to recognize that there are better ways to do the work that they need to do. To Err is Human actually had a message in it that was lost. Unfortunately, the title it pointed to a point failure. And the vast majority of patient errors are not about a point failure. They're about a systems failure. And so, to a large extent, trying to gain the confidence and implementation of tools and guidance to create systems change so that our care delivery systems are actually providing the highest quality of care is kind of where I would throw our limited dollars, and which is what we're doing through the National Action Alliance.
Although I might argue that the title pointed towards a theological rather than an operational solution. To err is human, to forgive is divine. But I don't think most of this group is really in a forgiveness move.
So, Bob.
As I said, we're in a crisis. We all need to be pulling on the rows, rowing in the same direction. And I really want to thank Patients for Patient Safety because they've been pulling on the row.
Yeah, we've been pushing that rock uphill for 20 years. Bob, thank you so much for the convening work you do at ARC to bring together organizations and the research that supports new ideas in patient safety. Looking forward, one of the things that's been a point of discussion in this conference and also is a priority for Patients for Patient Safety is more visibility to see the harm that happens. And patients really are frustrated that we still don't have a place to report our harm. And when you think back to the 2005 Patient Safety Act that created patient safety organizations, the intention of those really was to create learning and improvement that was shareable. And it's still very siloed. We have over 100 and almost 120 patient safety organizations, and only 10 contribute to ARC's national database that would support sharing of learning and would support researchers who want to learn. And frankly, that doesn't allow patients to submit their own experiences of harm. So patients can't submit harm, and functionally, most of those organizations aren't submitting to the national database. Where do you think we as patients could push to encourage that to change? Because we look at it as something that's not working for us and not giving us a voice.
Well, it's not working for a lot of us.
So where could we push?
It's not working for those of us who want to try to measure and understand and fix problems that are identified. I think one of the areas that you just described is one avenue. You said it was the development of an act of Congress. Certainly those kinds of acts can be modified and adjusted. And certainly you have ideas that you've put on the table that I think certainly the time that you were spending on the Hill, I hope you were sharing some of those ideas. And certainly the kinds of ideas that those of us in the federal agencies can react to and can certainly work towards. But there are also other things that we're trying to do internally with the PSROs and others to try to make that kind of data more visible. I completely agree with you. The invisibility of patient harms has been one of the most difficult issues to deal with, both as a cultural notion that somehow we all do great work, but if you actually ask people, well, would you take your mother or father there? They'd say, well, maybe not. And so the real question is, how do we begin to make those vehicles that we have available more functional? And part of it is actually, as I said at the beginning of my comments, to listen to the customer, to begin to create both patient experience measures that also capture when there are harms, that are more immediate in time so that healthcare systems and clinicians and others can react to them more quickly than the way we've historically thought of data collection in the federal government.
Yeah, we agree. It should be more real time, and we should have not just patient experience measures, but a safety measure in the patient in the
That's what I meant.
measures,
In
yeah.
the patient experience surveys, that including a patient safety related set of issues.
Yeah, that's
Because
very
that's there are several areas that the current consumer experience measures don't capture. One is patient safety, but it's also never captured the emotional and the psychological aspects of care delivery, which are central to whether or not people pursue their treatments or maintain their treatments, and a whole variety of other things having to do with care delivery.
and we can't capture it if patients can't speak up. So before we move on to our next presenter, I do want to acknowledge one thing that the patients in this room really have celebrated at ARC is the incredible leadership you've done producing the Candor Toolkit. And for those of you that don't know, after a harm event, there's this idea of, which was a novel idea many years ago, that ARC really pushed out with partners like Beta and leaders around the country to have open and honest disclosure after harm. And ARC created a whole learning toolkit, and it was really exciting to see a ARC partnership with CMS in the structural metric, that idea that was nascent at ARC and developed there now as part of the structural metric is something that hospitals all should be doing, being open and honest after harm. And that's the kind of collaboration that we're really excited to see. So
We've been pushing the Candor Toolbox with boards of trustees and others, because that kind of cultural change starts at the top. And the large systems, particularly multiple hospital systems in multiple states, have really, really adopted it. And it has turned out to be a very important tool that new trustees are learning about day in and day out.
And frankly, for those of us who have experienced harm, it's respectful and honest and supportive for both the patient and the employee. So let's move on to our next presenter. Marty, who do we have in your order of slides? I don't know the order of slides.
We have flexibility there, Beth, but I think we should hear from Dr. Yackel.
Okay. Okay. All right. Thank you.
Thank you.
Can I just page down here? Yes. Okay, cool. Well, good afternoon. Thanks to Partnership for Patients for inviting me, and particularly inviting the Veterans Health Administration to present to you today, and asking to present specifically about how we are addressing in the Veterans Health Administration the recommendations that came out in the President's Report, or the PCAS report for patient safety. I'll take 1 minute just to also state there was also a President's Report on artificial intelligence, in which I believe there were 4 recommendations for patient safety that we need to start thinking about and addressing. So I was interested in seeing that. At the center of your screen, you'll see the symbol for the National Center for Patient Safety. And as Bob alluded to, safer systems, safer care. We're focused on safer systems. Before we move forward in this slide presentation, though, I just wanted to give you a brief impression of the Veterans Health Administration, some facts maybe that folks don't know in the audience. We are the largest, or one of the largest, integrated healthcare systems in our country, serving over 9.1 million enrolled veterans annually, We have commitments to advancing high reliability principles and practices across 1,380 healthcare facilities, 170 VA medical centers, and 1,193 outpatient sites. The National Center for Patient Safety was established in 1999 by Dr. Kenneth Kaiser and led by Dr. Jim Bajan. So, as was alluded to by Marty, we are celebrating our 25th anniversary this year. I don't know if that's young age, middle age, old age these days, but we'll just go with young. We have a multidisciplinary team. Why is that important? Because each profession has a different way of looking at patient safety science. We have physicians, nurses, pharmacists, physical therapists, social workers, a broad range of healthcare system specialists, statisticians who help us to see the systems that we want to change to make all of us successful in providing care to our veterans and other beneficiaries that we take care of. And of course, our goal is zero preventable harm. So today you'll see some blue stars on your screen. This is the VHA's commitment towards new activities we'll take on in the next fiscal year to address the President's report. First of all, what's being displayed is the safety culture commitment. I think most of us know that culture eats strategy any day of the week. You have to change the culture of an organization. So Dr. Elnahal, in his comments at the White House today, alluded to this safety culture commitment. And what this is, you'll see 8 strategies on the right side of the screen. And the aim is to make the environment safe for our healthcare workers, as well as make sure we're providing the very best care to our veterans. And Dr. Elnahal signed it. It's leader-led. I'm sorry. And so, yeah, I need some more food. So it's leader-led. So leadership pillar and HRO is the first pillar. Continuous process improvement is the middle pillar. The end pillar is culture, and my office is very involved in the cultural piece, and we measure that each year. It's really, the safety culture commitment is our greater effort across the Veterans Health Administration to accelerate our journey to high reliability, and it really outlines actions leaders can take to foster a proactive safety culture. Why is that important? Because it's the leader saying, I'm going to give you the resources and time to do an appropriate root cause analysis to figure out what in the system failed so that your team is safer in providing care to our veterans. And so that's really a really important thing, to have that leadership buy-in that was alluded to earlier. And it's really a statement of shared responsibility, which really reflects the core values and ongoing endeavors to prioritize the well-being of staff and patients. We measure safety culture every year in the Veterans Health Administration through our all-employee survey. And we've been doing this since about 2019. And you'll see 2019 is in red, blue is 2020, the gold color is 2021, the green color is 2022, the purple color is 2023, and the most recently is 2024. There are 4 dimensions being displayed: teamwork, cohesion, and risk engagement, risk identification and just culture, supervisor trust and communication, and error transparency and risk mitigation. And so those are the 4 dimensions, and year over year, we have seen increases in each of those dimensions as a result of our high reliability and our culture efforts at improving culture. In case you're wondering, the response rate on these all-employee surveys is over 60%. So the statistics are pretty powerful here. And so I wanted to share those data with you so you could see the impact on culture that we're trying to achieve. And I want to see those bars higher every year, and I'd like to see greater growth every year, one step at a time now. So one of the recommendations was, how do we reduce disparities in medical errors and adverse outcomes? And so within the Veterans Health Administration, I wanted to let you know that we share a joint reporting system with the Defense Health Agency, or DHA. And we have this very same reporting system. We have the same structure. We use the same tool. So we can potentially capture the data for over 16 million beneficiaries. That includes the DoD/DHA and the Veterans Health Administration. And so I wanted to let you know that the Joint Patient Safety Reporting System is a voluntary system. And I wanted to let you know that since we integrated with the Defense Health Agency in about 2018, we have received over 1.5 million joint patient safety reports that our patient safety professionals have processed to understand the systems and to make our veterans safer. We have now worked with the Defense Health Agency to add demographic fields to the Joint Patient Safety System to better understand more about healthcare disparities for our veteran and active duty populations. And down below, you can see those fields that we were able to negotiate and agree upon. And so it's a first step as we start collecting those data to understand what those healthcare disparities are. The fourth pillar, the fourth recommendation is about accelerating research and deployment practices, technologies, and exemplars as systems of care. Displayed in front of you is one example of the technology piece. We have a team, a multidisciplinary team of people led by our biomedical engineering group who have a catchy phrase called the STAR team, and we do think they're stars. The Safety Triage and Assessment Repository team, what they do every day is truly impressive. Just an example this morning, they work at recalling IV pump across the system in every VA hospital because it was unsafe. Not only are they doing that, they're finding defects. So anybody in the VA can submit a joint patient safety report. There's a check mark. That check mark allows us to see what they're concerned about at the national level. Then we bring together a multidisciplinary group of stakeholders from across VA, and then also people like the FDA, many other groups, and then we make recommendations to manufacturers to fix their devices because they devise systems or devices that sometimes are not safe for our patients. So very proactive. So that's what this displays here. The FDA this year has acknowledged the work of our STAR team with 4 certificates of appreciation. So it's truly an impressive program. In an effort to accelerate research, I wanted to let you know about our Patient Safety Centers of Inquiry. These were also established in 1999 by Dr. Kaiser. They have produced over 300 peer-reviewed publications, and we have a PESCI, we call them. I don't know if that's a great name, but it's a PESCI, Patient Safety Center of Inquiry, that is looking at standardizing outpatient ultrasound to improve diagnostic safety. So if we're going to be doing ultrasound in the outpatient setting, which we know is kind of an untapped area for patient safety, how do we standardize that? How do we read it? How do we get those results to the patients? And then who does the quality check on that? Those are just some things. So just to focus on the slide in front of you, they are actually based in our facilities. We fund them to do research in the facilities. These could be residents who are not VA aligned, who are associated with Johns Hopkins or any other learning institution across the United States. But they do the research, and then they develop evidence-based toolkits to get that research into practice faster. Why? Because if many of you might know that peer research, I think the literature varies, takes 15 to 17 years to get into bedside practice. So to accelerate that, we ask them to develop, market, and then share their lessons learned through their efforts, through those toolkits. We also, to be more proactive and grow the bench, so to speak, we have a residency for residents in patient safety. It has graduated 971 physicians from various specialties to include and not limited to internal medicine, surgical gap and surgical post-residency, psychiatry, emergency and family medicine, radiology, and anesthesiology, to name a few. That's really impressive because these will be our future leaders in patient safety, quality, and high reliability. There are 60 facilities or medical centers that participate in this program across the United States. And this year, we were proud to announce we have 112 positions open for this academic year. We also have a fellows program for patient safety. We've graduated 206 fellows with a variety of backgrounds: nursing, engineering, public health, pharmacy, dentistry, and physician assistants. That's just to name a few, because safety is everyone's job. So we need all healthcare members to understand their role in that. There are 6 fellow sites and 14 positions open this year. And again, related to diagnostic safety, one of our residencies program at the San Diego facility addressed significant delays in patient harm and mammogram workflow by implementing lean principles to standardize processes, integrate a coordinated care tracking system, and redesign the mammogram menu in the computer and the electronic health record. These interventions result in a jump in timely notification of mammogram results from 67.5% to 100%, indicating a more efficient and safer diagnostic process. We also have recently started funding for our patient safety professionals. It's a patient safety innovation program. So what we want to do is we want to make sure those patient safety professionals at the facility have some money to implement evidence-based practices in their programs. And we were able to launch that in 2024, and we have funded 2 projects. And one of those is emergent clinical event team coaching prior to Code Blue, which is practice makes perfect and reduces errors, and pressure injury prevention. It's a bedside assistive technology device to help out those staff who help those patients who might be prone to pressure injuries. We have we also started and dusted off a program that was sunsetted. It was called the Cornerstone Program, but it's patient safety programs of excellence. And you can read the 3 dimensions that they were recognized for. There is the VA Boston Healthcare Systems, the James A. Halley Hospital in Tampa, Lexington, Kentucky VA Medical Center, Orlando VA Medical Center, the James H. Quinlan, Johnson City, Tennessee, Richard L. Rodebush in Indianapolis, Indiana, the William S. Middleton Memorial Hospital in Madison, Wisconsin, the Audie Murphy Memorial Veterans Hospital in San Antonio, Texas, and the Tiber Rubin VA Medical Center in Long Beach, California. 2 things in terms of committing. You see the blue stars here, and this is my last slide. We are joining with the Defense Health Agency to modernize our joint patient safety reporting system based on the current literature and patient safety science. And so we're moving the joint patient safety reporting system to a cloud-based application. And the focus of this will be proactive identification of potential harms in our systems. So instead of letting harm occur, when are we getting that signal to intervene before that harm occurs? So how can we do that? One thing about the Joint Patient Safety Reporting System that I did not touch on is that we already use artificial intelligence. Because it's a voluntary system, we use natural language processing to extract the data. And so we are thinking very critically about how to integrate AI into the future JPSR platform. We are also going to be doing a new root cause analysis, a joint root cause analysis application. We have been around for 25 years. If you've ever seen RCA squared, that came from the National Center for Patient Safety. And then the latest thing that we are dealing with or will be managing is taking underneath the National Center for Patient Safety a national program in 2025 for the prevention and management of patient falls across care settings. So when we look at the data, we see medication errors are high. One of our top reporting concerns, and falls in our veterans, the top winning concern. So these are what we're going to be focused on, and thank you for your time and attention today.
That was a really impressive presentation. Thank you so much, Ed. For those of you who don't know the history of the patient safety movement, having Ken Kaiser and Jim Bajian as your founding leaders is sort of like the Daughters of the American Republic, but without having to get together for tea. It is really impressive program. So I guess the question I had when I thought about what you're doing with the Defense Agency is your ability to influence the private sector. I mean, you've got relationships with academic medical centers, HSA. It would seem to me that in certain selected places where you have a lot of veterans and a lot of active military, Texas, North Carolina, South Carolina, places like that, San Diego, that you could take some of what you're doing and get some of the private sector to adopt zero preventable harm in a serious way that they have not, and also give them the tools to do it. And I'm wondering, particularly given the new announcements from the White House, whether or not the VHA with the Defense Department might consider a more targeted strategic outreach to some parts of the private sector to bring them up to the level of sophistication and intensity that you just demonstrated.
Thanks very much. So just so where we are part of the National Action Alliance and are really working with HRQ, CMS, and the other colleagues on this stage. And what we're doing is we're sharing what we're doing on the HRQ websites that everybody has access to. And so that's the important part is some things government, you're allowed to share publicly, you're not allowed to share publicly. This is one thing I can share publicly. Our HRQ colleagues put it on their website, and then we can share it more broadly there. But there are opportunities, no doubt, to influence this. But part of this forum today, being with all of you, is spreading the word about how we can partner better with all of you to make our systems better. And I look forward to working with everyone as well.
I was thinking something a little more targeted, like somebody from the VA in San Antonio and the Defense Department going to the local hospital council and saying, hey, this is how we do things. We'd like to talk to you about changing how you do things. A real, knocking on the doors, person-to-person outreach to kind of push the private sector a bit, maybe people who are members of the National Action Alliance, but has that kind of sort of targeted outreach been anything you all have discussed?
Local leaders at the facilities do collaborate a lot with their fellow hospitals, and I'm going to look at I'll go back and look into that if we have a targeted effort at that. I know that there's general information sharing,
Right.
but not the content of that sharing.
Don't hide your light under a bushel.
Right.
Yeah, I think I know how many great things you all have been doing at the VA, and I like that you're restless. And you just keep innovating. I mean, and really moving from retrospective about harm to prospective to predictive. And I think that transition is really exciting to patients, and your commitment to partnership is exciting. I wish I felt that same energy in the private sector. There's pockets of it that are committed, but I'll be honest, the mentality in the private sector that we as patients have experienced has been a little bit more pay me or make me. And you all have chosen to do this out of your own core mission to veterans. And so I think that's something strategically that we need to think about, how to create the right incentives so that everyone's doing some of the things that you all are doing. So thank you.
Thanks. So what I would just say is we have a board of chair people called Congress. Yes, and we have to. They ask us to answer their questions about why things are not going the way we want them, and so we frequently. I have talked to Congress. I have presented to the Senate SFAC and the Congressional SFAC in terms of different patient safety concerns that have been brought up in the environment. But having that mandate, that national mandate from Congress, you can't legislate everything, but at least you can start pointing in the right direction. And we do have a special mission in the VHA to serve our veterans the very best. That's why I do it. I mean, I could have retired after 30 years in the Army and said goodbye, but I'm like, you know what? I'm passionate about patient safety. I want to make sure my fellow veterans get the very best care. Let's break down barriers. Let's focus on systems. Stop blaming people, because we design our systems incorrectly, whether that's a process or people, you look at how we build old operating rooms, and we operate out of old facilities, and when they were built, they were fine for the time, but with that aged infrastructure, it sets the healthcare team up in that surgical suite, for example, for failure, because they can't see when someone comes into the room and they put an extra sponge on the sponge table, for example. So it's really about that for me. And so I don't know if that's a great answer, but it's certainly, I think it's my team back at the National Center for Patient Safety are restless. They're always looking for opportunities, always looking to push the envelope and really understand what is going on in the environment. And we realize we only get 20% of the information, and we want to do better. We want to get that information. So we're looking at other ways to try to enhance access to the Joint Patient Safety Reporting System. One of the barriers we're trying to decrease with the modernization project is decreasing the amount of time it takes for reporters, who can be anyone. All you have to have is an identity card to put in the computer. You can be a janitor, you can be a housekeeper, you can be whatever, the CEO. Anybody can put a report in, and then our patient safety professionals triage it. But that reporting form right now, electronic, takes about 8 minutes. That's too much time. People don't like putting things in computers that take that long. So we're looking to shorten that down so that it becomes easier for people to report, plus working on the culture piece to make it psychologically safe for people to speak up and know we're going to focus on the system and not penalize the person for making an error, like overriding a Pyxis machine that's beeping 24/7 or alarm fatigue kind of stuff.
Well, I love it. I love how restless you are. I love how much you've done, and I love how you're showing so many in the private sector that it can and is being done a lot better. But I know we have other organizations that are also restless and challenging us, so I want to give some time to our other speakers. Thank you, Ed.
Absolutely.
It's fantastic. Marty, Prita, thank you. The CDC.
Well, good afternoon, everyone. It's such a pleasure to be here, as well as an honor. I wanted to thank the organizers for inviting me and my colleague, Kerry Moran, who's in the audience today. She just waved. For those who cannot see, she's sitting in the audience. And also to be one of the distinguished panelists here. It's awesome to be in the midst of people who are truly passionate, and I would like to share some of the work that we have done at CDC and what we have. So this title of the slide set is about diagnostic excellence. I'm really happy and excited to report that as of 11 a.m. this morning, on World Patient Safety Day, with especially the focus on diagnosis, CDC, with collaboration with ARC and CMS, and support from many other agencies, organizations, as well as this organization, the core elements has been released. So I will talk a little bit more as I go through the slides. But before that, I just wanted to touch base a little bit about the division that we work in. You may or may not have heard of our division, so just to give you a little bit background, it was also something that I should have mentioned on Sunday night when we were having dinner, but couldn't speak to it too much due to the, listening to the lived experiences that the courageous souls in this room have is something I will take back, and certainly provides a lot of motivation to get to working on this. And so our first is, protect patients. We also want to protect healthcare personnel, promote safety, quality, and value in national and international healthcare delivery systems. But I added this, and I hope my division director will not mind, is to continue to collaborate with our partners to collectively work towards our shared objectives of enhancing patient safety. And that includes addressing health disparities and striving for improved healthcare equity. This is a long list of all our focus areas. You'll see there's a lot of interaction with what ARC does. But we also go beyond a little bit of beyond healthcare-associated infections. We work on antibiotic use, antimicrobial resistance, sepsis, adverse drug events, blood organ and tissue safety, immunization safety, and medical errors. And outbreaks, we work on a lot of prevention. You probably hear in the news that CDC has arrived at the hospital to work on outbreaks. So those are just some of the areas that we touch in the healthcare settings. But of course, sort of our bread and butter have been infection control. And I wanted to really stress that on the partnership with patients and families. Kerry here, our previous division director, Dr. Denise Ricardo, our current division director, Dr. Michael Bell, Dr. Arjun Srinivasan, they all are very instrumental in having us gotten us thus far. We want to collaborate with you to understand your perspectives. I think it provides really valuable insights and identifies opportunities for patients and families to advocate. We want to hear from you. If you don't tell us, we won't know. So we definitely want to hear from you. We want to equip patients with critical information to protect them from healthcare-associated infections, highlighting the significance of patient-healthcare provider relationship, addressing public awareness gaps regarding sepsis, infections, and antimicrobial resistance. To understand when an infection is improving and when it's not, and then educating the use of antibiotics, including potential risk associated with misuse. And I'll add one more here, and that is diagnostic safety events. So just to give you a brief history, since the establishment of CDC in 1946, one of the core programs that was started was infection control programs. The two instrumental studies in 1965 and 1974 actually were very interesting in the sense that they went to community hospitals and actually did what we call bread and butter of epidemiology and identified infection control practices that were effective, and then actually sort of, I guess, a randomized control trial tried it and found that they were effective. And thus was born around this time too was the National Healthcare Safety Network. You may or may not have heard of it, but that's where the hospitals report the adverse events that are experienced by patients related to healthcare-associated infections. And that's widely used by infection control practitioners. And CMS here uses the data to observe hospital performance and inform patient payment decisions. Local and state health departments use this data to understand where they can focus their prevention efforts, and we also work with ARC because they as well work with healthcare-associated infections, and we can tend to focus our interventions through that. You may have heard of the Healthcare Infection Control Practices Advisory Committee. In short form, it's called HICPAC. We've had a patient representative on that forever, as long as I can remember. And it's very instrumental to have that kind of representation because, again, we want to hear from you. During this time, I want to say in 2000s, Congress mandates are really strong. It helps us move the needle in many ways possible, and we've been collaborating with CMS to determine about the HAIs. And in 2010, the Congress incorporated the Healthcare-Associated Infection Prevention into the Affordable Care Act's value-based purchasing program. And the first healthcare that was selected was the central line-associated bloodstream infections. In 2009, the National Action Plan to Prevent Healthcare-Associated Infections Road to Elimination was released with updates in 2013 and 2018, and there is a current update coming up. This is a slide from the NHSN network. Anything to your left that's in gray was pre-2019. The line that's bluish gray is 2019, and anything in blue is when the pandemic started. And you can see that in this case, the device-associated SIR, we call it standardized infection ratio, went up during the pandemic, and that was due to the various stresses the healthcare systems had. Everyone was working, they were overwhelmed. We had patients, individuals. It was just all around, irrespective of who you are. The virus didn't really care, and it affected our healthcare systems. But the good news is that infection control programs are coming back into the hospitals. They are putting things into place. And in 2023, although it's not shared here, it's actually coming down. And as shared by AHA, similar information we are seeing in NHSN is the first quarter that they are on the decline. This is related to C. difficile infection that is usually caused when someone takes antibiotics and their microbiome in their gastrointestinal gut is affected. And the other one is methicillin-resistant Staph aureus bloodstream infections. It's interesting to note that the C. diff infection has been on the decline, which also shows something that I'll talk a little bit about is our antibiotic stewardship programs. MRSA did go up, and now it's on the decline as well. So the next topic is antimicrobial resistance, and in 2013, CDC released the antibiotics resistant threat reports. It examined the burden and the threats and raised awareness, and in 2014, the White House released the U.S. National Strategy for Combating Antibiotic Resistance Bacteria. And the same year, for the first time, CDC released the core elements of hospital antibiotic stewardship programs. So that's just a brief history of where we have been working and the space we've been working. And I think one of the objectives was to learn about what we have been doing in the area of patient safety. But now I'll just slightly switch over and focus on the core elements because of, this is what I would like to share with you. So what is the core elements? They are a set of key principles. It outlines structural, procedural components. They're actionable. It has to be a collaborative effort towards improving patient care. It can be applied across any healthcare systems. And the examples provided are stratified by priority and the others that can be utilized. And it serves as a roadmap and framework. And incidentally, it also aligns with what the National Action Alliance Plan was that Dr. Deb Howry presented in terms of identifying practices for organizational level actions and systems level change. So in 2014, CDC released a vital signs. It's very interesting if you ever have the opportunity to Google, 2014 seems really long time ago, but it isn't. And the vital signs showed that how much of antibiotic use was not appropriate. And during that time, they came out with 7 core elements. It was leadership, accountability, drug expertise, action, tracking, reporting, and education. 7 core elements that are all actionable and can all be implementable. And then in 2019, based on more evidence, it was slightly changed that drug expertise became pharmacy expertise, because when you deal with a drug that's called antibiotic, you really need that kind of expertise to look at, not just someone who's a clinician who's been trained, but actually a pharmacist. And then since 2014 to now, there have been multiple core elements released, which are basically can be applied to all systems, and including health departments. And then during this time as well, we started working on diagnostic stewardship, and in 2019, there was a meeting convened at CDC where you had representation from the federal, the industry, professional, and patient relatives. And what it showed basically was to do any kind of diagnosis, it had to be the right test for the right patient at the right time to inform optimal clinical care. And that it had to be part of the antimicrobial stewardship. And the figure on your right shows how the two of them are really interconnected, and that you have to do this together, that they're not separate events, but actually very much intertwined. And in 2023, when coming out of the pandemic, sepsis is a huge problem. We never forgot about sepsis. It still continues to be an issue today. And the core elements for hospital sepsis program was released. And that too had modeled on the antibiotic stewardship, it had 7 core elements as well. So you might be asking, so what releasing these core elements? But the interesting thing is it's so actionable and it's simple enough to have that colleagues in CMS and the Joint Commission have used this to ensure that the patient gets the right antibiotic for the right time and at the right time. And now we are working on the sepsis core elements to improve the monitoring and management of sepsis. And so we come to the core elements of hospital diagnostic excellence. So the link at the very bottom is the link. It's rather long, so if you just want to Google diagnostic excellence, CDC core elements, I think it should pop up. I tried a few times this morning after 11 a.m. and it's working. So please go ahead and try, and I encourage you to. And it follows the same. It's modeled after the 2 core elements, but this is actually co-branded and co-released by CMS and AHRQ, and it's certainly an honor to have that, because one thing as we were looking and writing this and thinking about it, we seeked input across, including this organization here. We asked for input, and as someone who writes papers and who writes policy and who reads that, the amount of honest criticism that came in, suggestions, if there was a red pen that we used to use before we started doing electronic tracking, which makes everything look really nice, when you do a simple markup, it would have had a lot of red marks on it. And the only reason I say that is because it shows that this topic is really near and dear to a lot of the people, especially, not just patients or clinicians or organizations, but actually everyone sitting in any chair in any aspect. Because I think the most important thing is we are humans, we are patients, we will walk through the doors of a healthcare system, we will see a doctor, no matter what age and what time we are. So this core elements, it was really a warm-hearted feeling to actually know that there is a lot of passion behind this. So multifaceted goals is to reduce patient harm. We really wanted to get to zero harm, support programs to improve diagnosis in all areas of the hospital, improve quality of patient care and health outcomes, and improve efficiency in identifying challenges. It covers all medical conditions. It complements and supports a lot of what you'll hear today. It's kind of nice to see that the core elements actually brings all of this together. And it connects the dots. So the figure on your right actually shows how everything that we work on is eventually connected. Yes, of course. So I'll go very quickly for the next 2. And I just wanted to indicate these are some of the defining terms. We talk about diagnostic safety events. And then, the core elements of diagnostic, I just want to highlight that the patient, family, and caregiver engagement is what we've really highlighted, and it's very different from the other core elements. These are some. It's very long, but you can I've tried to highlight here some of them. It's about communication, understanding patient priorities, and encouraging patient families. Hospital leadership commitment and accountability, we really want the systems to change, and we really want it to be monitored and make sure regular communication happens. Knowing that the patient really walks through and meets a number of individuals, we thought, we wanted it to be of multidisciplinary expertise. Action and tracking and reporting, we've tried to focus on 3 things that there's already published literature on: diagnostic stewardship, strengthen systems and processes, and identifying and learning from diagnostic safety event. And then education, we could all learn something from each event. And so these are the tools that have been released. It expands our healthcare system, has anywhere from small hospitals to very large hospitals, and they all cater. But the most important thing is there's actually a patient tool, so please look at it. Please share your feedback. If you've missed anything, these are all living documents that we all can change together. And then the next steps is that we'll continue to be working with our federal partners and partners like you to make sure that we can continue to move the needle forward in terms of patient safety. And that's my last slide. Thank you.
Thank you, Preeta. And Ruth Ann, why don't you go get set up while we just ask a question of Preeta, because I know we need to move along. The CDC has such an important role. What would it take for the NHSN database to allow patients to report into that database? What kind of funding, what kind of changes? You know, these things are not just things that our hospitals are tracking, but patients are experiencing. To have, you know, a database is only as good as the information that goes into it.
Right, so the current mandate is, you know, to get reporting from the hospitals. And I think I feel like we've repeated this over and over again. As long as we have a mandate and we can get the Congress to say, you know, please accept that, I think we can definitely do that. You know, the division does have some kind of precedence in this. We have something called the WES report, and we have had VSafe, especially with COVID-19 vaccine, where individuals can actually report it. And that came out of a request, you know, to make sure that we were capturing adverse events due to COVID-19 vaccination. So there is some precedence, and we're hopeful.
I'm hearing a thematic issue is that we need to knock on some congressional doors as patients.
Yes.
But I do want to switch to Ruth Ann now, because there's a little bit of this check and balance and the interaction between the agencies. And what OIG does, and Ruth Ann's going to describe it, is really important, because if that harm is not being reported, you know, that's a challenge. Right. And so I'd like to hand off to Ruth Ann. No, we're a little behind, Michael, so we're going to wait. Thank you. All right, thanks, Ruth Ann.
Yeah, I can go faster. I think many of you, I've spoken to this group before, so probably heard. I'm speaking on behalf of our OIG adverse events team today, but I also have a personal story, and I've told that as well, so I think I'm familiar to everyone. I've worked for the OIG for almost 30 years, and our adverse events team has been working on establishing incidence rates in various settings for nearly 20 years now. And I want to talk a little bit about that work and what makes it unique in the event that it might help in terms of what we view as the biggest problem we have now in making progress in patient safety, and that is that we're not all speaking the same language. We don't all use the same nomenclature. For the few of you who don't know who the OIG is, we perform an oversight function for HHS operating divisions. There are 13 of them, and we have 3 represented on the stage, CMS, ARC, and CDC. And we engage with the agencies in regard to their programs and outcomes. And then we also, our big business is fighting fraud, waste, and abuse in the healthcare provider community. So most of our folks, we've got nearly 2,000, are investigators and agents who fight healthcare fraud. But our little niche does research to help support the operating divisions like CMS and ARC. So our OIG work, this will depress Beth because she's asked me to go quickly, but I'm going back a few years because it's what kind of tells our story. We were given a mandate by Congress in 2016 to develop an incidence rate, a national incidence rate of adverse events, of harm events. They initially named the NQF serious reportable events, the NEVER events, which most of you know is a relatively small list, so we quickly broadened to all-cause harm. The thing that makes the OIG rate unique is that we're really looking for everything. It doesn't matter if it's a harm of omission or commission. It doesn't matter if it's now, at this point in time, preventable. If there's a harm event, we capture it. And the way we're able to do that is Congress, somebody was brilliant in mandating that we develop an incidence rate, because an incidence rate, by definition, requires the denominator to be a whole population. So in other words, when we go into hospitals, and we've gone into thousands of them, nursing homes, inpatient rehab, long-term care hospitals all over the country, we have to take a national random sample of those charts. So The majority of charts we're looking at are people who didn't know anything happened. There was no ping, there was no report, there was no complaint. The person didn't know anything. They may not have walked out of the hospital. They may have declined and died as a result of their event, but no one in their family knew it because they didn't understand how medical care can create a harm situation parsed from all of their comorbidities they might have had and their primary diagnosis of even being in the hospital in the first place. So that's the work we've tried to do, is look at all charts so we can get a true numerator, a true frequency of how often events happen. And what happened with that, we interviewed tons of experts, including, I can't believe David Klassen is in our audience. I had Dr. Klassen on speed dial for a decade. All these experts, we talked to all the ERA's human authors, Dr. Berwick, Dr. Wachter, Lucian Leap, famous legends in the community, and decided that what was missing in patient safety research was that we were identifying lists of events, the ones we all know about and should be identified, CLABSI, CAUTI, and so forth, but that there were a lot of things people weren't paying attention to, acute kidney injury, fluid overload, that can cause a patient to decline and have complications, but wasn't on any list. So we ended up identifying thousands and thousands of events with this all-cause harm definition. Undesirable clinical outcome resulting from medical care, not caused by underlying disease, both omission, commission, preventable or not. And we hired these cadre of experts all around the country, nurses, physicians, to form a panel for us. We used to spend Monday nights, every Monday night, talking about these cases. They'd review the case, and then we do our own sort of M&M with our analysts, figuring out what happened in this case. We had every lab value for the stays that didn't even have any kind of sniff of any kind of problem, and we found a lot of problems. And so what we've been able to inform, selecting a national sample, nurses screened the records through a trigger tool that Dr. Klassen actually invented. The physicians conducted a full review. We had a physician panel discussing the cases, and the medical coders who repriced the claim. That was another gap we identified, is nobody really knows what this costs. Of course, the human toll, the opportunity cost is terrible and much more important, but we also wanted to be able to talk to the CFOs and say, how much is it really costing? Medicare, Medicaid, and then the providers themselves. So how safe for patients? These are our, just in a nutshell, results. The two in green, I think, are the most important. We did a pilot study when we didn't know what we were doing, and through the kitchen sink, we studied every possible method, including talking to the patients and their families, at a small number of hospitals, and found a 30% harm rate. 30% of the people who left the hospital had something bad happen. And these weren't near misses. These were actual harm events that required a medical intervention, all the way to permanent harm, requiring life-sustaining intervention, elongating the hospital stay, and contributing to death. We had all those. Then we did a national study in 2010 in hospitals, 27% harm rate. Nursing homes, 33%. Inpatient rehab, 29%. Long-term care hospitals, 46% harm. In part explained because those are obviously very long stays, those of you know about LTACs. We went to Indian Health Service hospitals. They're owned by HHS. So we went there. That included births, children, and found a 13% harm rate in the general population there. Then here was the big report that and I believe Dr. Schreiber talks about this in her remarks as well. When we went back 10 years later, so we did an initial report of hospitals, 27% harm rate, went back 10 years later, it's still old at this point, 2018 records. These things take years to do these medical record reviews. We found a 25% harm rate, no statistical difference. So in the 10 years when all of us had been focusing on patient safety, 2008 to 2018, we got, a few things improved, absolutely, but we got no statistically different change in the rate, which blew our minds and was just alarming and devastating for us. And so just very quickly, what's driving these numbers? Why didn't we see improvement? What else can we do? We have in our reports all kinds of parsing about diagnoses. Misdiagnoses are, to me, most heartbreaking cases. Deaths because of delayed surgeries, for example. We have severity of harm, preventability, what made something preventable versus not. The type, medication, patient care, surgical, we've got that all parsed out. We have every single one of our thousands of events actually listed and described that you can do word searches on. Top 5 reasons for preventable harm. The key one here is in yellow. The medical error should not be a synonym for harm event. That only about 20% of our events had an actual, what clinicians would call a sharp-end medical error. Much more important were the systems issues, substandard treatment, inadequate preventive care. These are issues of the nurse not visiting often enough, inadequate care plans, inadequate monitoring. Error of judgment? No, it was systems problems and multifactorial. In my personal story of my event, I had 5 different, actually all of these were represented, leading to a death. And so we can't oversimplify, it doesn't do us any favors. Why didn't we see any improvement? Nomenclature. We think the number one thing is nobody's speaking the same language, and some people are starting to really game the system. If you talk to some people who are not as well-intended as everyone in this room about improving safety, they'll say, we don't count side effects. We don't count known complications. Those are harm. Count them differently if you want. Categorize them, sure. But you've got to count them as harm. It's ridiculous to let people off the hook and not have improvement programs because something is a known complication. In this sophisticated medical world, almost everything is. So we found actually that only 14% of the time did the hospitals know. We went back where we had identified an event through our rigorous method. That only 14% of the time did the hospitals even know the event happened. And guess what? None of those 14% were the permanent harms or the deaths. None of them. They didn't know a harm event had occurred. And we were talking with the C-suite. And we have an upcoming report. This is the most important thing before I stop. Coming out by the end of the year, and it's going to update all this information. What percentage of events did hospitals capture? So we're going to have a new number for that 14%, a current number. What are the reasons that events weren't captured? What are the outcomes of the events? Like what system changes did they make? And then what else can we do? We have the same ideas as everybody else. Capture it all. Increase transparency, patients, families, and make safety a hospital-wide priority. And that doesn't just mean to the CNAs and the nurses, that means to the CFO, to the risk management folks who might be thinking of patient safety in a slightly different way. We have a bunch of toolkits online that give you some more guidance about exactly how we defined events for anyone who wants to read those. We tried to make them accessible, they're online. And then key takeaways at the very end, a wide range of harm events occur. Only a small number were the ones that we expected. Harm is nuanced, not all causes are errors. Providers often don't know the event occurred. The cost of harm is devastating in human terms, but also in financial terms and in opportunity cost. Think of what we could be focusing on if we weren't focusing on these harm events. You can find all our work really easily online. And this is the name of our team lead, Amy Ashcraft, who will answer your email in seconds if you want to reach out to her about any of this work. Is that close?
That was great.
Okay. Thanks.
Thank you, Ruth Ann. And now we're going to hear from Michelle. But Ruth Ann, I just want to, as Michelle gets set up there, want to say how grateful we are for the process and the rigor of what you're doing and your organization is doing, because it really sheds light into the, state of the sort of, we can't improve what we don't know about. And what your research and your analysis has said is we don't know about a lot. And so what we're really interested is, how do we know about more? And not just that, the ones we do know about still aren't getting reported to AHRQ, to CMS, and to CDC. So right now, isn't that a false claim? If you charge for something that you technically was a never event and you shouldn't have been paid for?
Well,
I mean, as a taxpayer, I kind of have concerns around that.
We do have, so the IG has 150 attorneys who do that type of work. And worthless services is the claim that we typically make. If you were harmed in the provision of your care, your services were worthless, and Medicare, Medicaid shouldn't be paying for them. So there's a huge body of work trying to go after that. The problem is you can't report what you didn't identify. So if the family, we found this, we spoke with families and patients, and they walked out the door not knowing. My child, my parent declined. And that makes sense to us intuitively because we don't have that clinical head. We don't know all the ins and outs. So reporting is nowhere if you're not identifying. So that's the limitation. So yeah, we're trying to, continue to identify the wide range. And I didn't get to AI, but we're in so much of a better position now than ever to be able to do that because now everyone has EMRs. We have overlays now that can detect harm in real time. We should soon be in a much, much better position to be able to, I won't be telling you about old data anymore. We should be able to monitor this continually in real time as a government and assess it. I don't think that's far away.
I love that idea, and also the link to risk management, that, if we're only tracking it on the front end of the house in the EMR and not also coordinating that data on the back end of the house in the risk database, we're kind of missing a link there.
Right.
And especially if we're not allowing patients to report their harm anywhere else. I know when we lost my son, we couldn't report it anywhere, and we got billed for it for $90,000 for the next 2 years. And chased down by creditors for that. And we were the 5th family in 4 years that same error happened to, totally preventable. So at some point, we got to fix this. And we have all the people in the right chairs. We maybe just need a little more congressional pressure. So let's pivot and over to Michelle and hear what CMS is thinking about the situation. Thank you, Michelle.
Thank you. In order to save time, I'm going to forego slides. But I kind of want to speak in large part from the heart. When I graduated medical school, which my kids tell me was before electricity was invented, I actually took the Hippocratic Oath that said, first, do no harm. And I've spent my entire many-year career trying to figure out and remediate why healthcare doesn't behave that way. We need to get to a point where first, do no harm is the first priority. And what's so encouraging is that I think we are more equipped to partner together, including with the patient safety advocates, to be moving that along even further. One of my best friends actually died of a diagnostic error. He went in for a CT scan for a totally unrelated reason to what ultimately happened. And the radiologist found and read accurately a mass on his kidney. But because they were actually looking at it for a totally different reason, that slipped by. It was read, but the physician didn't pick up on that. There was no notification system. My friend, who was also a physician, didn't have access to his records or chart because he'd have seen that immediately. And those of you who know this, who can figure out this story, can understand that 4 years later he died of kidney cancer that could have been taken care of much earlier. So I have spent a lot of my career really dedicated to patient safety and quality. And it's part of the reason, actually, that I went to CMS. So I'm very privileged to have been at CMS for the last 5, almost 6 years now, working on quality and safety strategies, which the agency prioritizes very highly and is embedded deeply into our national quality strategy, which speaks to equity and safety and outcomes and resiliency. What we saw during the COVID pandemic, and many people have talked about that here, was the decline, the precipitous decline of patient safety during that time. And it wasn't because people weren't working hard. And it certainly wasn't because the workforce isn't engaged or cared about it. It's because the systems that support safety and the systems that support quality aren't really resilient. And at a time of overwhelming stress, they kind of fell apart. The good news is that we are rebuilding that, and most recent data shows that we're getting to pre-pandemic levels, but that's not good enough, as Ruth Ann points out already. So our focus has to be on how do we then collectively really support systems of safety and making sure that this is how we do business. And I'm so actually grateful to the VA because their high reliability organization skills that I know you're making public, I think have truly led to great improvements. So what is CMS doing? Well, first of all, the Centers of Medicare and Medicaid Services, if you're not familiar with us, we are a payer. We're probably the largest payer in the country, maybe on the planet. And we're also a regulator. So I guess the make me and or pay me is, we're both. And we have put together a number of strategies working across our agency. That means Medicare, Medicaid, the Innovation Center, the Center for Quality, the QRS marketplace system. We're working collectively and collaboratively across our entire agency. We've identified what are the top harms we want to look at and are working on strategies to move forward. We stole shamelessly, frankly, from Beth and from those of you who are patient safety advocates, where you said, see harm, fix harm, don't pay for harm. So our strategy is promote transparency, a little bit more political words, right? Promote transparency, partnerships for improving safety, and working on incentivizing zero harm wherever we can. In terms of transparency, we try very hard through Care Compare, and Care Compare has multiple sites, hospitals, nursing homes, and so forth, to make performance transparent, and through our STARS systems to also make performance transparent. And through our measurement, quality measures that go on to Care Compare and inform STARS, we will look at introducing new measures. So this year, some of you probably saw the patient safety structural measure. And I have to say a shout out to all of you in the patient advocacy group. You carried the day with your comments and the letters that you wrote in, because there was opposition when CMS proposed the patient safety structural measure. But your support is what made this happen. So from us to you, thank you. It matters. We also finalized the age-friendly measure, which we hope will support the advancement of care for the older population. Near and dear to my heart, I guess, these days. Beyond transparency, what are our partnerships? Well, our first partnership you can see in evidence here. I will say that the federal government is working very closely together in collaboration. AHRQ, CMS, CDC, FDA, ONC, OIG. We truly are working as partners to speak with one voice and to advance patient safety. And to all of you, thank you. But it really is a very intentional effort for us to align our efforts and to use the strengths that each of us brings to the table. The second partnership obviously has to be with the workforce. We have to be sure that we are including workforce safety and the psychological harm from error in everything that we do. Because in order to have a resilient healthcare system, we need workers and workers really believe in safety and quality. So this is a win-win for the workforce when we focus on safety and quality. And finally, we need to partner with you, with patients, because bringing the patient voice to bear is extremely important, and how we can better do that through measurement or through systems of reporting error. I think we are still identifying, but we are committed to partnering with patients, with you, because your voice really is what brings this and makes this real. And finally, when we talk about incentivizing zero harm, we've been asked many times, well, why don't you just not pay for it? And there are rules that allow us to not upcode or pay for more if harm occurs, but that's really not enough because there's so many, codes on any bill that most bills get paid for fully anyhow. Some of this requires congressional action. The Deficit Reduction Act of 2005, also almost 20 years old, like the Patient Safety Act, limits some of what we can do, and so this is mandates for what we can do. But we're also looking at other means of incentivizing zero harm, such as our rewarding excellent care for underserved populations, where we move our scoring methodology to incentivize certain things, in this case, particularly around equity. Or what we're doing in our STARS rating, where some of you have seen in our outpatient rule proposal, looking at how we can change the STARS rating to weight safety more heavily. Should CMS, for example, be giving out 5 stars, in other words, our gold seal of approval, to any organization who has bottom barrel safety performance? And so that was the question, and we look forward to your comments there as well. With that, please understand that all of us together as federal agencies, all of us combined within our agencies, are truly committed to the goal of safest care for all and zero preventable harm. Thank you.
Thank you, Michelle. You know, there's a modern way of saying some of what the Hippocratic Oath does. There's a Stanford professor said there should be a sign above every operating room. There are some patients we cannot help, but none we cannot harm. Do we have time for a quick question or not, Marty?
We are at time, but if I could ask the
Very
moderator to
quick
wrap up
question.
your comments.
You have a
And thank
wonderful
you.
commitment to patient safety, but I look at some of the deemed organizations for CMS, like the Joint Commission, and they are not showing the same passion. For instance, with a standard for hand hygiene that sets no goal and specifically says we are not going to audit your entire organization to see what you're doing. So you want to go from 10% to 15% over the next 3-year period? That's fine with us. So the question is, to what degree is CMS trying to imbue the state health agencies and the accrediting agencies with the same spirit that you've shown us today?
That's a good question.
I try.
I know. We do partner very closely with our state agencies, with our surveyors, with the people who write the conditions of participation, and patient safety is certainly first and foremost. Those were the reasons for the conditions of participation. So I will take your question back to CMS because we think patient safety is of fundamental importance, and I don't know why that particular thing around hand hygiene is an issue, but we will try to find out.
Michelle, there was also a proposed rule here to really strengthen the oversight and the connectivity of accreditors with your standards this year that we filed comments on. So I hope those made a difference.
Yes.
Yeah.
And hopefully, since we're talking about things like that, hopefully you're seeing CMS move forward in the conditions of participation. This year, for example, the proposed condition of participation around maternal care, making maternal care more safe. The proposal around nursing home staffing ratio mandates, for example. So CMS really is trying to advance safety through these mechanisms as well.
And you're advancing electronic health measures, clinical measures, I mean, to get at more visibility of the harm that isn't reported.
See, I didn't talk about it because I was trying to save you time.
I know.
I could talk about that forever.
I love the
But yes, one of the things that CMS is very committed to is driving our measures to digital measures. That gives the ability to, number one, capture the robust clinical information that is in the electronic medical record that can't be found just on claims data. Number two, it provides more opportunities for real-time feedback and for trigger tools that come out of the electronic medical records so that organizations can react very quickly. Plus, of course, it gives the opportunity to layer on advanced analytics and ultimately AI. And I know David Klassen is in the room. We support the work of electronic trigger tools. But I will tell you one anecdote. Electronic measures and electronic trigger tools, they find a lot of harm. And sadly, we've been hearing anecdotes of organizations that have started to use some of these tools only to turn them off because they found too much harm, which to me is completely counterproductive. You know, more harm reporting leads to better care. But we have to be transparent and non-blaming and build the culture that supports that.
I just
Amen.
Yeah, let's wrap it up. Yeah.
Yep.
Yeah.
Do you want to wrap it up?
Yeah, we just want to wrap it up. And I have to say, a few years ago, many of us were kind of discouraged about safety and the accessibility of these leaders to answer our questions, to think about them deeply, to think about innovative solutions is really inspiring that we can and will become safer as a country. And the idea sharing from the VA to private institutions across your organizations, we still have a big rock to push up a hill. But I'm very inspired by the leaders here today. Thank you.
We are not going to take any questions. I'm sorry, but you can maybe get to some of our speakers as they're crawling up the stairs to the end. But Bob, Prita, Ruth Ann, Michelle, and Ed, thank you so much. And Michael and Beth, thank you so much for a fantastic panel tonight.